Good morning, ladies and gentlemen. My name is Shesov, and I am the professor of anesthesia and intensive care at the Department of Anesthesia and Reanimatology Valery Gerik from Chisinau, Republic of Moldova. And it's my great honor to be here today as an invited speaker and to share some of our experience in the field of obstetrics, anesthesia, and intensive care. So I would like to take this opportunity to thank Professor Tkachenko for this kind invitation and for this opportunity. Uh, let's start. So I work in the busiest perinatal center in the Republic of Moldova. We have more than 5,000 natural deliveries and 100 C-sections per year. And that data means that every fourth child in Moldova actually is giving birth in our hospital. And related to today's topic, I want to mention that I have no conflict of interest to present. Anyway, I'm going to talk about the Cytosorb and its use in our practice, and I also will share some benefits that we think that are quite important for the Cytosorb. By the way, Cytosorb is an extracorporeal blood purification device that is used to remove substances like pro-inflammatory cytokines, bilirubin, myoglobin from the blood. And actually, it works by passing blood through a cartridge filled with absorbent, polymer absorbent, and that absorbent works like a sponge that actually remove the substances from the bloodstream. I'm really fond of obstetrics because in obstetrics you have a feeling, or at least me, I have a feeling that I'm a part of some sort of divine providence because you are really involved in the giving birth, or at least in helping giving birth to the new babies. But besides this bright and lucky part of our daily activity, there are also complications, dramatic complications that can lead to maternal mortality and morbidity. And it doesn't matter if you are a provider in a developed country or in a low-income country. The complications are right there, and we all face them. And as you see from these pictures from UK, even if there are a lot of initiatives to improve maternal outcomes, still there are a lot of women that have different type of complications. And generally speaking, among these complications, probably the most frequent we face actually the peripartum hemorrhage. It's a very huge phenomenon all over the world. It can affect up to 14 millions of women in the entire world, and it's by far the leading cause of maternal mortality, and it represents about 30% of all causes of maternal deaths all over the world. So a little bit more numbers, 10% of all deliveries will be complicated by PPH, and severe PPH has a constantly 4 to 5% of incidence rate in last 20 years. Talking about Moldova, we have in last years, we actually faced a decrease of maternal mortality ratio from 30 cases per 1,000 live births to 12 cases per 1,000 births. And in Moldova as well, 1/3 of all maternal deaths are due to PPH. We know that PPH is a problem and maternal hemorrhage is a problem for many, many years. And we have actually in place now a lot of tools, a lot of strategies and algorithms that help us to fight against PPH, against massive hemorrhage. But this improved the management of massive maternal hemorrhage actually greatly reduced maternal mortality on one hand, and on other hand, maternal survival has improved, and awareness of the rates of rare complications from the hemorrhage-induced ischemia or coagulopathy becomes crucial. So the maternal bleeding can set a chain of events, of dramatic events that lead to multi-organ dysfunction, from coagulopathic bleeding syndromes like CID, like Dick syndrome, and to renal failure and to endocrine complications. And we have really to be ready to act and to provide adequate treatment for these complications that used to be very rare, and now we see them more and more because we are able to improve care for maternal hemorrhage. And now I am going to share with you with some clinical cases from our practice. Case number one, it's case of a 37 years old lady that was brought to the hospital early in the morning. And she was pregnant, 39 to 40 weeks of pregnancy, G2P2. And actually, she was brought to the hospital because to the perinatal center because of the onset of first stage of labor. Nothing special in her medical history. She already delivered several years ago a nice baby through a vaginal delivery. No comorbidities. Her weight was 67 kilos, height 160 centimeters, BMI 26.7. So the decision was quite straight. No comorbidities, no special features. So patient lady was addressed to the delivery unit, and actually she delivered at a little bit later during that day, almost 7 or 8 hours later, because so she developed an acute fetal distress, and then vacuum extraction was in place, and spontaneous vaginal delivery was finished at 13:45. But as it can happen, some complication appear on scene because of use of vacuum extraction and fetal distress. Actually, she developed a perineal laceration stage 2, and a blood loss of only 200 milliliters. As management, the obstetricians decided to put the sutures on the laceration, and even anesthesiologist was not invited for this procedure that was considered to be quite minor. But on the next day, early in the morning, patient lady started to feel very unwell, and it took several hours to set up the diagnosis and to do USG and to do full blood count. And then actually, the result was obvious. There was a hemorrhage, intra-abdominal hemorrhage. So with a huge delay from my point of view, patient was admitted to the OR, and a hysterectomy with ligation of vaginal arteries was performed. But as I said, it was late from my point of view already, and the total amount of hemorrhage was estimated to be 3,600 milliliters. So patient has definitely a hemorrhagic shock. So we use tranexamic acid, we use isotonic balanced fluids, we use red pectorate cells and cryoprecipitate and fresh frozen plasma and so on. But due to this huge hemorrhage, it looked like it was not enough, and patient was put on norepinephrine, epinephrine, dobutamine, and a little bit later, at the end of the surgery, patient was transferred to the ICU. In the ICU, she has a quite unstable condition till the next day. You can see that norepinephrine, epinephrine, dobutamine was still on roll, even if there were no signs of anemia at that time point. And of course, you can now see that this hemorrhage, massive hemorrhage, and use of increased doses of vasoactive drugs did not pass without complications. So she started to have huge, important changes in her lab workout. Well, we needed to have a way to treat this patient, to have this patient a chance to survive. And we started to look into the literature, what we can do in order to help her. So you can see from this meta-analysis that was performed over 2012 to 2023. and included more than 335 patients that actually use of hemabsorption techniques for critical ill patients with acute liver dysfunction or liver failure seems to be quite safe. And in pooled data analysis, the authors were able to confirm that use of hemabsorption can reduce the bilirubin concentration as well as influence the creatinine concentration. Even more, if if you look into individual cases, you can see that hemabsorption can dramatically reduce the concentration of aspartate aminotransferase, bilirubin, creatinine, C-reactive protein, and need for vasopressors. The author's conclusion was that it's really safe and it's really worth to use hemabsorption in case of acute liver failure. One another study done by the group from Romania showed actually that the use of Cytosorb in comparison with Mars was associated with significant decrease in lactate, in ammonia, bilirubin, and lactate dehydrogenase. And they actually stated that, Cytosorb can help in rebalancing liver function in patients with acute liver failure. And it will do better. This task will perform better this task than Mars. Other studies show as well that Cytosorb works much better than other extracorporeal techniques to reduce the total bilirubin level, and that I think is quite important. However, we have to acknowledge that we have quite nice studies that show that Cytosorb is not good in terms of reduction of the ammonia level, and actually dialysis can reduce ammonia level much better than Cytosorb itself. But in our case, we can use right now Cytosorb only in tandem with dialysis, with hemodialysis filtration. So it doesn't actually scare us too much, and it was in any way quite inspiring for us to start to consider to use Cytosorb for this lady, and to use it in a combination with the continuous venous hemodialysis filtration. Because we had a patient with acute kidney injury, definitely we have a patient with hepatic failure due to ischemic hepatitis, and we have a patient with refractory hyperthermia. So we started to do continuous venous hemodialysis filtration with Cytosorb, and actually in a quite short period of time, less than 24 hours, the patient status improved dramatically. She became hemodynamic stable. We were able to wean her off from any vasopressors or inotropic drugs, and you can also observe that laboratory panel improved a lot. So here you can see some recommendations from our colleagues from China, and actually they say these recommendations come from this recommendation actually states that in case of acute liver failure, fatty liver failure in pregnancy, we have to consider use of hemabsorption any time when there are symptoms of severe central nervous system abnormalities, when there is a persistent coagulopathy dysfunction, when there is a severe renal dysfunction, and of course when there is a progressive decline in cardiopulmonary function. So I think it was really our case, because our patient had most of these indications in place and it really was a good idea to do the CRT with Cytosorb. By the way, the patient was discharged on the 7th day from ICU, and on the 10th day she was discharged home from the hospital. The next case is a case of 20 years old lady that was transferred to our hospital from another institution. She already arrived with the diagnosis of septic shock after hysterectomy due to endometritis, and she was in 18 weeks of pregnancy. So when the hysterectomy was performed. At the admission to our hospital, she was quite unstable from hemodynamic point of view. You can see that blood pressure was only 90 over 70 and heart rate about 97. She was in anuria for more than 12 hours. She was on norepinephrine, and the abdomen was post-operative quite distended. Well, the treatment of this lady was quite complex, as her clinical status was not the best one. And again, we focused on the early use of continuous venous hemodefiltration and Cytosorb. Even if there are not many publications that are encouraging the use of Cytosorb for critical patients. For example, in this systematic review, authors were not able to prove that Cytosorb can improve overall mortality or mortality due to sepsis or cardiopulmonary bypass surgery and so on. Again, even surviving the sepsis campaign, the guideline from 2022 does not provide any statement on the use of blood purification techniques in septic patients, just because there are not enough data, not enough evidences on the table to advise pro or contra use of purification techniques. In the same time, there are quite nice studies, studies that are performed so far on small cohorts of patients, but as you can see from these charts, use of hemabsorption techniques can really help to decrease interleukin-6 concentration, to increase mean arterial pressure, to decrease lactate level, and overall to improve the survival scores of the patients. So we actually decided that there is nothing to lose in the case of this lady with septic shock, with acute kidney injury, and we started to do the CRRT. We're using Cytosorb in her case as well. Well, and as you can observe from this graph, actually, the need of norepinephrine in her case started to decrease, but please pay attention that we started to see the decrease of norepinephrine dosage only 12 hours after the use of Cytosorb. So actually, this was the time when the Cytosorb was actually already used and substituted by another one. And I think it's quite important to stress out this thing, that whenever you use any CRRT technologies and any hemabsorption technology, don't expect that your patient will improve immediately. Give the time to your devices, give time to your technologies, because due to huge load of interleukins and other metabolites, it is really need some time to have the patient on the machine, on the filter, in order to get a clinical improvement. Well, there are always something in the dark. There are always something around the corner, and even cases that might look very simple can bring actually huge challenges. Like it was in this case of a 38-year-old lady that arrived to the hospital with a history of fever for last 48 hours. Her fever didn't drop below 40 degrees Celsius, and prior to admission, she used absolutely uncontrolled the paracetamol and and SATs. So she was in the 27th week of pregnancy, G1P0, and the onset of labor actually was present. Our colleagues obstetrician did an emergency C-section with hysterectomy due to sign of infection in the uterus, and they left us a patient with septic shock, with community-acquired pneumonia, with peritonitis, with endometritis, with HELLP syndrome, and acute kidney injury. So if you look at the septic shock and the acute kidney injury and severe metabolic acidosis, it looks like that it's enough to consider the use of at least continuous venovenous hemodefiltration, and Cytosorb. But HELLP, what to do with HELLP? As you know, HELLP means and the low level of platelets. So in our patient, they were only 13 platelets, and the use of heparin for anticoagulation was quite challenging. In literature, at least American Society of Apheresis suggests that HELP is 100% indication for cases when the HELP is in postpartum, developing postpartum period, if it's a class 3 HELP, or even in antepartum period, if it's a HELP class 4. But they actually stress that it should be used the therapeutic plasma exchange for the sake of HELP. In our case, we actually decided to use Cytosorb as well. And in order to overcome the HELP and low level of citrates, low level of platelets, we decided to use instead of heparin, citrate as an anticoagulant in order to preserve the work of buff filters from CCV, HDT, and Cytosorb. The results were quite fast, so you can see that in less than 48 hours, she improved dramatically, and fortunately, her clinical status improved much, and was discharged home together with her newborn baby. So, on the end of this talk, I would like to make several take-home messages, several statements. And first of all, please be attentive, because obstetric practice is not free of complications. There are a lot of risk factors, and complications can arise whenever you don't expect them. Also, hemosorption for critical ill postpartum women seems to be a safe and might improve the outcomes, even if there are not a lot of data on this, and maybe there is a lack of really strong evidences. But if we use hemosorption as an adjunction to a complex therapy treatment approach for critical care patients in the postpartum period, and we are looking very carefully for patient selecting, then yes, hemabsorption Cytosorb is a good and important option for our patients. Thank you for your attention, and I will be more than happy to answer to your questions during the Q&A session. Thank you.